Hello, I'm Swathi Jothi,
I'm Mahima Zandu.
first year internal medicine residents at University of Arizona College of Medicine South Campus. Today we'll be presenting a case of an elderly male with rapid devolution of a right atrial thrombus to a life-threatening supraventricular tachycardia secondary to Apixaban failure. So, right atrial thrombus is a fairly rare entity with an incidence rate ranging from 2 to 7%. There's also a lack of consensus on the right choice of anticoagulation for an RA thrombus. This is a case of right atrial thrombus causing supraventricular tachycardia. So we have a 62-year-old male with past medical history of congestive heart failure with preserved ejection fraction, status dermatitis, COPD on 2 liters of home oxygen, chronic hepatitis C, remote history of provoked DVT, was non-compliant with warfarin, and RV thrombus on Eliquis, which was started 2 weeks prior to presentation to the ER. He presented to the ER with gross hematuria, vomiting, and left flank pain. On exam, he was afebrile, mildly hypertensive, tachypnic on room air. Upon initial laboratory evaluation, CBC was remarkable for slight leukocytosis with neutrophilic predominance, and the CMP showed borderline decrease in renal function with an elevation of NT-proBNP to 2,372. He underwent a pan-CT imaging which revealed bilateral thromboembolic disease, a new RA thrombus, and an existing RV thrombus, which is demonstrated on Figure 1, 2, and 3. Looking at Figure 1, we can see clots in the bilateral pulmonary arterial vasculature. On the right, the yellow arrow shows a thrombus in the right main pulmonary artery, which was extending through the lower lobe segmental vessels and right middle lobe segmental vessels. On the left, there was a clot extending from the left lobar pulmonary arteries to the left upper segmental arteries, and a few areas of the clot were seen in the lower lung subsegmental vessels as well. Figure 2 demonstrates a CT image of a RV thrombus measuring 2.5 centimeters into 1.4 centimeters, while the orange arrow in Figure 3 shows a right atrial thrombus that measured 1.3 centimeters. Cardiology was consulted given the findings of right heart thrombus, and the patient was started on a heparin drip. But shortly after the initiation of treatment, patient was found to be in SVT, hemodynamically unstable with systolic blood pressure in the 90s and heart rate in the 180s. He was initially refractory to vagal maneuvers like Valsalva and ice baths, and to 3 pushes of adenosine. He was then given a 150 mg bolus of amiodarone along with 5 mg push of IV metoprolol, which helped convert him back to normal sinus rhythm with a rate in the 80s. Pulmonary embolism response team was consulted. The echocardiogram at the time demonstrated 50 to 55% of left ventricular ejection fraction, a mild to moderate tricuspid regurgitation, elevated RVSP between 50 to 60 millimeters of mercury, and signs of severe right ventricular dysfunction. Figure 4 is an echocardiogram showing an echo density in the right ventricular apex measuring 3.7 into 2.2 centimeters, suggesting a thrombus.
He was then transferred to CT surgery, where he successfully underwent bilateral pulmonary thromboendarterectomy and clot removed from right atrium and right ventricle. Prior to CT surgery, patient had a cardiac catheterization performed as a part of preoperative clearance, which demonstrated a 2-vessel coronary artery disease within left circumflex and right coronary artery, and severe precapillary pulmonary hypertension and a reassuring cardiac output of 4.9 liters per minute. Cardiac catheterization was reperformed and 2 stents were placed in the RCA. Hypercoagulability workup during the hospitalization was unrevealing for any prothrombotic state. His subsequent recovery was essentially unremarkable. So the management of RA thrombus is a subject of debate. There are several options for treatment of intracardiac thrombi, including anticoagulation, embolectomy, or thrombolysis. There is a debate regarding the choice of anticoagulation, warfarin versus direct oral anticoagulant. Here is an instance where Apixaban led to poor clinical outcome, and the definitive treatment was embolectomy and lifelong warfarin. We have a study which reported a 7.6% failure rate of Apixaban when used for venous thromboembolism. Other DOACs showed the following failure rates. Rivaroxaban was at 65.8%, followed by dabigatran at 27.8%, and edoxaban was at 1.3%. There is paucity of randomized clinical trial when it comes to treatment comparison for intracardiac thrombi. A recent meta-analysis revealed non-inferiority of DOACs to warfarin in LV thrombus management. However, a retrospective study by Robinson et al. Evaluated LV thrombus management by comparing warfarin, DOAC, and a crossover study group, which showed that DOACs in the study were associated with an increased risk of systemic embolization or stroke. Pending a negative malignancy evaluation, it is postulated that the increase in blood flow in the presence of the RV thrombus led to development of bilateral PE and the RA thrombus. Given his pre-existing RV thrombus, we believe the additional clot burden increased the right heart strain and increased myocardial oxygen demand. Considering that cardiac catheterization revealed significant coronary artery stenosis, the increased oxygen demand was unable to be met with appropriate supply. This mismatch precipitated the episode of SVT. Our patient had a near-fatal event with the development of new RA thrombus and PE despite being on Apixaban. We highlight the scarcity of data on appropriate RA and RV thrombus management, which can prevent life-threatening complications. Considering the treatment failure, our case demonstrated, and we can safely conclude that additional studies are warranted and choice of management should need to be individually determined.